Okay, welcome everybody. Thanks for joining in. We're going to allow just about 30 seconds for all the attendees to be allowed in by Zoom, and then we will get started.
Can I go ahead and screen share? Should I get that set up right now?
You can, absolutely.
Is that best? Okay.
While we're waiting for the attendees to file in, this is Dr. Kelly Roszko and Dr. Rachel Gafni. They both work at NIH, and they will be giving us a talk today on autosomal dominant hypocalcemia, which is also known as ADH1. It's a mouthful.
And assuming you can see my title slide, is that up?
Yes, we can absolutely see that. And it looks like the participants have leveled off. So whenever you want to start, Dr. Roszko, you are all set.
Okay. Great. Great. So good morning, everyone. And again, thank you for having us. Oops. Wait. Sorry, I'm not sure if my slides are advancing. Is this going to advance slides? Oh, there we go. Can you see my disclosures up right now? Did it advance?
Yes.
Okay, great. Thank you. So these are our disclosures. And today I'll be speaking to you about autosomal dominant hypocalcemia type 1. This is a quick outline of what we're going to be speaking about today. So first, I'm going to tell you a bit about normal parathyroid gland function. Then I'd like to talk about what is ADH1. And finally, in my portion of the talk, I'll be going over some characteristics of ADH1 patients. We'll talk about conventional treatments that many patients are on right now. And we'll also talk about the complications that are specific to ADH1 that we look out for. Okay, so to begin, let's talk about the parathyroid glands. So the parathyroid glands are located behind the thyroid. They're circled here in this picture. They are 4 small glands, and they're found in the neck. They're very important because they make parathyroid hormone. The main function of the parathyroid hormone, or PTH, as we usually call it, is to increase blood calcium. So when your body detects a low blood calcium, the parathyroids are going to release parathyroid hormone to increase that calcium back to normal. So it does this in 3 main ways. First, it releases calcium from the bone. The bone, as you know, is a big storage repository for calcium, and the PTH allows the stored calcium to be released when you need it. The next thing that PTH does is it acts at the kidneys. When PTH acts at the kidneys, it tells the kidneys to hold on to calcium and prevent the calcium from being lost into the urine. And finally, also at the kidneys, the PTH promotes the activation of regular vitamin D into calcitriol, or that activated form of vitamin D that many of you might have heard of. Active vitamin D then goes to the intestines, where it increases the ability of the gut to absorb calcium from food. So again, increasing that body's calcium intake. So PTH is going to allow you to use the calcium that you have stored. It's going to stop you from losing any more calcium and increase the calcium absorption, all of which are going to help to bring the calcium level back up in the body. Now, here is a bit of a complicated picture about the calcium sensing receptor. So the calcium sensing receptor shown here is what we call a G protein coupled receptor. We call it that because it has a protein called a G protein that sends its signal inside the cell. But before we go any further in the talk, I just wanted to review the calcium sensing receptor so that you could see what it looks like. Like I said, it's a very long protein, and there are 3 main parts. So here you have the outside part. We call that extracellular. And this is the part that's going to actually detect the calcium present. Then there is this part that is in between the cell membrane. It's called transmembrane, and it has 7 times that it crosses the membrane here. And finally, there's this inside the cell part or intracellular part. And this is the part that's going to signal to the cell to tell it what to do. So the calcium sensing receptor is located on many, many cells throughout the body, but we are going to focus on the parathyroid cells and the kidney cells. And in those cells, it's really exists in the highest numbers in the body. So on parathyroid cells, it senses low calcium, and in response, it triggers the parathyroid cell to increase PTH. The kidneys, we're going to discuss more later, but at the kidneys, when it senses high calcium in the blood, it signals the kidneys to release calcium out into the urine. So here's a diagram. This is a diagram of a parathyroid cell here, and you can see the calcium sensing receptor on the cell membrane, and it's telling the parathyroid cell when to release PTH here. You can see it's got a machinery that's going to be making parathyroid hormone, and the calcium sensing receptor is going to keep the blood calcium in a very narrow range. It's usually the normal range is about 8.5 to 10.5 milligrams per deciliter. So it's going to sense the calcium outside here, and then this signal protein is going to tell the machine what to do to make parathyroid hormone. So one way we like to think of the calcium sensing receptor is sort of like a thermostat. So, your body has a set point, just like you would set the heat at your house. What point do you like to live? And like I said, this would be somewhere between 8.5 and 10.5 here. And as it goes up and detects too much calcium, it's going to shut down the parathyroid hormone machinery. But when it goes this way and there's too little calcium, it's going to turn on that parathyroid hormone and make more of it. So talking about the calcium sensing receptor like a thermostat, in this situation, it's detecting a cold temperature or that the calcium is low, and then it's signaling to the cell to make more PTH. And this more PTH would be like turning on the heater to heat up the house. And then the PTH acts, as we said, at the bone and at the kidney and at the intestine to increase the blood calcium. So that is the way that the body gets your calcium back up. And the opposite is when there's low calcium and the calcium sensing receptor detects not enough. Again, there's going to be a signal inside the parathyroid cell, and it's going to cause this parathyroid hormone to be increased. And like I said, when it's high calcium, it's going to detect a lot of calcium and turn that machine off, which ultimately is going to decrease the amount of calcium in your body. So I also mentioned that the calcium sensing receptor is found in the kidney, and it's very similar to the parathyroid glands. When the calcium is high, the calcium sensing receptor is going to tell the kidney to get rid of calcium by putting it out in the urine. So it's going to increase urinary calcium. So now let's talk a bit about autosomal dominant hypocalcemia type 1, and let's say, what is ADH1? So this is a rare type of genetic hypoparathyroidism. Its prevalence is 1 in about 70,000 people. What happens is there's a change in the calcium sensing receptor that causes it to be stuck in the activated state. And sometimes we call this a variant, sometimes it's called a mutation. So any of those words indicate that there's been a change to that calcium sensing receptor. Now the body is tricked into thinking that the level of calcium in the blood is higher than it actually really is. So let's go back to that thermostat analogy. Imagine if the thermostat is broken And even though it's freezing in the house, the thermostat here is reading 80 degrees. So it's not going to tell the heater to turn on, even though you're really cold, and the house is going to stay cold. And that's a really similar thing to what's going on here when the thermostat is broken, or the calcium sensing receptor in ADH1. So like I said, similarly, because of that activating mutation, even though the blood calcium here is low and could even be less than 8.5, the faulty thermostat is detecting that the calcium is high. And therefore, there's no signal here, and PTH is not produced, resulting in a lower calcium. The parathyroids think that the calcium is high, but it really isn't. So this is shut off, and there's really no way for the body to increase its calcium appropriately. In the kidney, the calcium sensing receptors are also affected in ADH1 patients. And as a result, again, the kidney thinks that the blood calcium level is too high. So it is going to excrete even more calcium into the urine. So these patients then have an inappropriate increased calcium in the urine, even though their blood calcium is very low. And that has two problems. The first is that it's hard to bring the calcium up when you're losing it in your urine. And the second problem being that there's really too much calcium in the urine. And later on, we'll talk about how that's not good for the kidneys. So to summarize the findings that we see in autosomal dominant hypocalcemia type 1, there is low blood calcium, there's low parathyroid hormone levels, the blood phosphate, which we haven't spoken about too much, but that is elevated because of the PTH, and the urine calcium is also can be elevated. So again, in summary, remember that the thermostat is broken and the ADH1 set point is wrong. The receptor is just too active. So the calcium sensing receptor signals too much calcium, there's really not enough, and PTH is just not released. So a few things to remember about ADH1 patients. These patients do have parathyroid glands that develop from birth. So that's unlike some of the other genetic forms of hypoparathyroidism. The glands are capable of making normal PTH. Again, unlike some other forms where there's a variation in PTH itself. There's no destruction of those parathyroid glands, as there might be in patients who have autoimmune disease, that there's destruction there. These are just parathyroid glands that are receiving the wrong signal. So now I'd like to tell you about the characteristics of ADH1 patients, some conventional treatments that are the current treatments being used, and the complications that are specific to ADH1. So I would like to tell you about some of the gaps in knowledge and a study that we're currently working on to learn more about this disease. As I said, this is a very rare disease, which means that there are many case reports which describe a single patient or case series, which talk about a handful of patients, but there are not very large studies that really talk about the disease. So we set out to put this data together. We aim to pull cases out of the literature so that we can combine them all together and make conclusions about a greater number of patients who have ADH1. So we did a literature search using these terms for autosomal dominant hypocalcemia, ADH1, genetic or congenital hypoparathyroidism, familial hypoparathyroidism, hypercalciuric hypocalcemia, and activating CASR variants. We looked at all the papers that were published between 1996 and 2021, and we collected the data from each study that we found. This actually brought us up to 70 papers. So we are in the process of going through all these papers, and we're compiling the data from every patient that they describe so that we can really get an idea about what the patients are all showing taken together. So I'm going to just backtrack now to go back to the calcium sensing receptor, and let's look a little closer at this protein. So this is actually made of 1,078 little building blocks These building blocks, represented by all these tiny circles, are called amino acids. A change in one of these amino acids can cause the receptor to be too active, as we talked about, leading to ADH1. So the PTH is then not released. So in this diagram, which was previously published by Al Salame and Al, the red and black stars are showing areas where there are activating variants in the receptor. Additionally, this receptor does have a chance of having inactivating variants. Those are shown here as the green stars. These people have the opposite condition of ADH1, and they actually have very high PTH levels and calcium levels that are elevated and low urine calcium levels. So it's interesting that you can see here how there are many places where the variations occur all throughout this receptor. In some places, a change can cause the receptor to be activated or inactivated, depending on which amino acid or building block is substituted into the protein. So some patients with ADH1 might know what their specific variation is. And if you're out there listening, you might actually be able to see where your variation is. It can be helpful if you're looking to trace this illness in family members, because we can look specifically at that area in this large gene to see if a family member has or doesn't have that variant. So in our study, we're going to publish an updated copy of this diagram as we're now compiling 294 published cases of ADH1. And we are finding 108 unique activating variations in the calcium sensing receptor. In our study, we found that 54% of these variations are in this outside the cell or extracellular domain, 33% are in the transmembrane domain here, and 13% were inside the cell itself. Other than 7 variants, which can be more severe, we found that in general, which variant a person has does not change how severe or mild their ADH1 behaves. In fact, some families, siblings can have the exact same variation, but one is much more severely affected than the other. And honestly, we're not really sure why this is the case. So this is the summary of our study. We have compiled information on 183 patients who had information about their symptom onset published, 90 patients who had their initial laboratory values, and 58 patients who had information on outcomes after they were treated. So first, we're going to discuss the findings on symptom onset and how these patients were diagnosed. So in order to do this, we need to talk about the inheritance. How is ADH1 inherited through the family? Because 78% of these cases were familial or inherited from a parent. ADH1 is inherited in what we call an autosomal dominant manner. Autosomal means it's carried on one of the regular chromosomes, so not the X or the Y, which are called the sex-determining chromosomes. Dominant means that if you have the variant, you can show this disease. It doesn't matter if the other gene from the other parent is normal. If it's dominant and you got it from one parent, you have the potential to show that disease. Of course, as we're going to see, not everyone shows the disease as severely as other people. And importantly, what this all means is that every time a child is born to someone who has ADH1, there is a 50% chance that that child will also be affected with ADH1. So you can see here there are 2 parents. One is affected, the darker blue, and the darker blue has like a 50% chance each time a child is born, there's a 50% chance that that darker blue gene will be passed along to that child. So then in the patients cohort that we looked at, 19% of the patients were found to have de novo mutations. A de novo mutation means that the person's parents do not have that variant in their DNA. It's a new variant that developed just in that person, sometime just before or just after conception. This person's siblings are not at risk of having ADH1. However, now this person has an autosomal dominant variant, and that can be passed to their children by the 50% rule that we just discussed. And finally, in these studies, 3% of the inheritance is either neither of these or unknown. Now, how did most people get diagnosed with ADH1? Well, 70% of the patients were diagnosed because they developed symptoms. And now, interestingly, despite 78% of the cases being familial or transmitted from parents to children, only 24% of the cases were identified through family screening. This could be for a few reasons. For instance, sometimes a parent could be discovered to have ADH1 after the child. However, I think it's important to note that this could also be because the parents might be diagnosed with idiopathic hypoparathyroidism and not know the cause. And perhaps their children were not screened because it wasn't thought to be due to a genetic cause. I think these findings of 78% of the cases being familial should prompt increased screening and genetic diagnosis, even for those who have idiopathic hypoparathyroidism, because knowledge of having this genetic disorder could really help diagnose children and reduce the risk of severe symptoms when they present, such as seizure. And finally, for diagnosis, 6% of these diagnoses were really just made due to an incidental finding. This means that people had blood drawn for another purpose or just for routine screening, and they found that their calcium was low. These patients really had no symptoms or no problems when they were diagnosed. So let's move on to the age at which patients were diagnosed. The age of diagnosis varied widely. The diagnosis of hypocalcemia in general ranged from birth all the way to age 66, with a median or middle age of diagnosis of 6. However, the diagnosis of ADH1 itself was even further delayed, with an age range of birth to age 77 and a median age of diagnosis of 25 years. As you can see, some patients were not diagnosed until very late in life. And this is likely because, as you'll see in our coming slides, the disease varies greatly in severity between people. So this chart is showing the presenting symptoms of the patients. And as you can see, 27% of them here in blue were asymptomatic, meaning that they had no hypocalcemia-related symptoms at all. 33% had mild or moderate symptoms, and these were known as muscle cramps or spasms, bone or joint pain, tetany, paresthesias, brain fog, or fatigue. And then 39% of patients had their initial presentation be with severe symptoms, and these included seizure, loss of consciousness, and laryngospasm. And of note, the most frequent initial symptom was seizure. That 38% of the patients presented with seizure initially. This is a very severe symptom that can be life-threatening, and we would like to strive to diagnose patients before they have such a severe presentation. So the median age of diagnosis varied significantly, with severe cases being diagnosed at a median of 1.3 years old, but other cases at a median of 14 years. So as you would imagine, these more severe patients usually showed up earlier in life. And these are the initial calcium levels from all 90 patients who had calcium values reported. Not surprisingly, the calcium was significantly lower in severe ADH1 cases than in moderate or asymptomatic cases. And in fact, you can see this sort of step down here, with the highest calcium being in the asymptomatic patients, then the moderate, and then the severe patients having the lowest calcium. And this gray bar is just showing all the patients taken together. So we also looked at the percentage of patients with each laboratory finding and found that on initial studies, 99% of the patients had low blood calcium, 59% had high blood phosphate, 59% had low blood PTH, and 35% had high urinary calcium. When discussing urine calcium, I want to bring up this study by Yamamoto et al., which looked at initial urine calcium levels in patients with idiopathic hypoparathyroidism or ADH1. So the first two groups here are patients with idiopathic hypoparathyroidism due to an unknown cause. And as you can see, their urine calcium values are mostly low or in the low normal range. This gray box is the normal range. However, these next two groups, 3 and 4, are showing 9 patients with ADH1. You can see that their urinary calcium values tend to be in the upper part of the normal range or even frankly elevated. And importantly, these are values measured before they were on any sort of treatment. So their blood calcium levels were low, but their urine calcium levels were inappropriately elevated. Here we show data from 58 patients who were treated for ADH1. And you can see that the majority of patients, 56%, were treated with active vitamin D only, while 42% were prescribed both calcium and active vitamin D, and 2% were prescribed only calcium. Unfortunately, I don't have the data about treatment outcomes for each of these specific groups. We were not able to divide that out. But we have been able to summarize treatment outcomes for the entire group as a whole. So the average blood calcium of the treated patients increased 24% to an average calcium of 8.1 milligrams per deciliter. And this is right below the reference range. 23% of the patients had blood calcium measurements that got up to the normal range. And it's important to remember that we often have a goal of keeping the urine calcium just below normal, in the low normal range, to prevent the urinary calcium from increasing, which we're going to discuss next. But of the 34 patients who did report the effects of treatment in the literature, 24 of them, or 69%, reported improvement of symptoms while on treatment. So it's important to note that 31% of the patients didn't have symptom improvement. And this emphasizes how our current standard of care is often not adequate to control the symptoms of ADH1. So this graph is going to show the urine calcium versus the serum calcium. So this is the serum calcium here on this axis, and up here is the urine calcium. And these are in idiopathic hypoparathyroidism patients, not ADH1, that are treated with either active vitamin D, the solid lines, or vitamin D and calcium, those are the dashed lines. And what's important, and why I put this slide up, is as you can see, as their blood calcium levels go up, so do their urine calcium levels with treatment. So we want patients' blood calcium levels to come up to help cure their symptoms, but we really want to avoid and get concerned when these urine calcium levels climb. And here you can see that in our review of ADH1 patients, the same pattern was seen. And the cases of hypercalciuria increased significantly when the patients were treated. You can see that 34% of the patients had high urine calcium levels before treatment, but after treatment, 66% of the patients had elevated urine calcium levels. And of note, like, these are frankly elevated, not even just in the high normal range. So why is urinary calcium so important? Why do I keep talking to you about it? Well, we're very concerned over complications, and particularly kidney calcifications. There are 2 different types of kidney calcifications. One of them is kidney stones, and these are also called nephrolithiasis. They are stones that are located in the tubes where the urine flows, and they can block the urine, causing pain, and sometimes require procedures such as lithotripsy, which would break up those stones. This is a diagram of kidney stones, and you can see that the stones are in here, the tubes where the urine is being collected, or they can actually come down into the ureter, which is the big tube bringing the urine down to the bladder. So you don't want blockages in any of these tubes. This second type of kidney calcification is called nephrocalcinosis. This describes calcification that occurs in the kidney tissue itself. You can see from this picture, when the kidney tissue itself becomes calcified, up here in these tissue regions, that's what we would be talking about, these top 3 circles being areas of nephrocalcinosis. The bottom circle would be where a kidney stone or nephrolithiasis would form. So in our survey of these cases in the literature, we categorize the complications as being kidney stones, nephrocalcinosis, kidney or renal insufficiency, and brain calcifications. Now, of note, I want to say, while we see these brain calcifications on CAT scans, we have no reason to think right now that they cause a clinical problem to the patients. But as far as these kidney complications, we found that there were complications in 76% of the total ADH1 patients who were getting treatment. And of note, there were complications in 47% of those who had a urine calcium that remained in the normal range, but there were complications in 88% of those patients who had high urine calcium or hypercalciuria. And this shows how the high urine calcium is likely related to increased complications and how important it is to keep that urine calcium controlled in our patients. So in hypoparathyroid patients, the urine calcium should be monitored, especially when they're on treatment, and especially in ADH1 patients who really can be prone to this problem. High urine calcium can be associated with a greater chance of complications, and specifically, those are kidney and brain calcifications. So in summary, the majority of ADH1 patients have a variant in a gene inherited from a parent. In most cases, the ADH1 is diagnosed because the patients have symptoms. ADH1 patients have a wide spectrum of symptoms. They range from asymptomatic to severe, and many present with seizures. ADH1 can be diagnosed in early childhood or in late adulthood, likely because of this wide spectrum of symptoms. And the average urine calcium levels are lower in patients with more severe initial symptoms. And finally, treatment cured symptoms in 69% of the patients, but urine calcium tended to increase while they were on treatment. Patients with high urine calcium levels generally had more complications than patients with that normal urine calcium. And in conclusion, we think that ADH1 patients could benefit from novel therapies, especially those therapies that would not increase the urine calcium, and that's very important for them. So I just want to show my team here. It's amazing, from the skeletal disorders and mineral homeostasis section at the NIH, the NIDCR. And I especially want to say a thank you to all of our patients and all of you patients who are out there watching us today. We really appreciate you, and you really motivate us and to do this work. So thank you for all that you do. That's it. So.
All right, very good. So do we want to take a few questions before we move on to Dr. Gafni, if that's okay?
Yeah, I think so. And I just wanted to say that some people are putting questions in the Q&A and some people are putting questions in the chat. And I actually answered a question in the chat, but then I realized nobody actually saw the question. So I put the answer without the question. So I apologize for that. So if you want to read the question.
Yes, that's what I figured I would do.
Sorry about that.
No
because but certainly people can write into the Q&A as well.
Very good, very good.
Anyway, sorry, my bad.
No problem at all. I'm going to start actually in the Q&A section. And Caddy had written to us and said she suspected that her son had ADH1. His genetic testing came back with a VUS, which is the variant. What is it?
Variant of unknown significance.
Yes, variant of unknown significance on his Kaiser gene, but not pathogenic. Is it possible that he does indeed have ADH1, but we can't prove it by a way of genetic testing yet?
That's a difficult question. You know, the variant of unknown significance means that we haven't seen it in other patients yet. So we can't say for sure that that's what's causing it. But I think that we do want to kind of keep thinking about that and whether that could be a cause. It's very hard to know in these cases when we get, like I said, over 1,000 amino acids, and unlike some diseases where there's really one spot that's always the problem, this could be anywhere in the gene. So I think it's hard to know when it's unknown, but we do sort of treat these patients as that we would want to look for other causes, want to make sure that we're not missing anything when there's a variant of unknown significance. And I don't know, Dr. Gafni, do you have anything to add on that? I know.
Yeah, I mean, obviously family history is really important. So if you have multiple generations or multiple family members that have the clinical condition, then it certainly seems likely that a variant of uncertain significance would actually be a pathogenic variant that just hasn't been reported before. There's these different methods, and Dr. Roszko knows about these better than I do, to try to determine or estimate if a pathogenic variant is a significant variant by looking at the way the variant acts in cells in the laboratory. Of course, these aren't 100%. So this is one of those things where you might see words like clinical correlation is recommended. So, if you have a patient that really has a classic phenotype of ADH1, and in particular has a much higher or a very detectable urine calcium, even when the blood calcium is very low, that might make you feel like this is likely to be a true pathogenic variant that just hasn't been defined. And then, of course, if your child's child has this same hypoparathyroidism and also has that variant, that would confirm that it's pathogenic. But obviously, that's many, many years down the road. But this is one of those clinical correlation is recommended, and it probably won't, it may or may not change the way you manage your child's hypoparathyroidism.
All right, very good. And let's see, I want to throw in a compliment here from Anne. Wow, another great presenter. Love it when these amazing professionals can speak to us on an understandable level. So thank you so much for that.
Thank you.
And let's see, which one should we go to next? Let's go to that one that Dr. Gafni was talking about. So my geneticist still thinks I might have an issue with the Kaiser gene. Although I was later genetically tested for DiGeorge syndrome, which was positive, I was born hypopara and I was a patient. So, Dr. Gafni, you had replied to that.
Yeah, that's not the question I actually replied to. I replied to the question before that one, but I can reply to this one too if you want.
Well, I'm just trying to see which one that was, what your answer was for. Does one need to have all 4 lab findings for a doctor to order genetic testing? Low calcium, low PTH, high urine calcium, and high phosphorus. That's the one I think you replied to. Yeah. You do not need to have.
Right. So what I said was that to make a diagnosis of hypoparathyroidism, all you need to have is a low blood calcium with a not elevated parathyroid hormone level, because the parathyroid glands are pretty smart. And so if you have a low blood calcium, the parathyroids should respond right away and the levels should become quite high. So even if they're in the normal range or low normal range, that's inappropriately low in the face of hypocalcemia. Not everybody has high phosphorus. Not everybody has high urine calcium, particularly at diagnosis. So, and the term idiopathic, and I'm sure other speakers are going to talk about this, but the term idiopathic is kind of this waste bag diagnosis, which basically means that we just don't know what's causing. But as we learn more and more about the genetics, the number of people that have true idiopathic hypoparathyroidism is really decreasing. So with all of these genetic testing panels that are available, and as you can see what Dr. Roszko showed, this variable age of diagnosis, we're definitely recommending genetic testing in anybody who doesn't have post-surgical hypoparathyroidism, particularly if they're diagnosed below the age of 40.
Okay.
And I went back, I don't know if you can see this slide right now, but just to sort of firm up these are ADH1 patients who have, diagnosed ADH1, and you can see on presentation, many of them did not have a high blood phosphate and did not have a high urine calcium. So those are definitely not necessary for the diagnosis.
Okay, very good. And may I ask, how would they go about getting the genetic testing that you're talking about?
So that can be ordered by their physicians. I would probably recommend that. There are, and if that's been a huge problem, to contact us at the NIH. But I think the best way is to go through a physician who can order these genetic testing. Usually there's a panel that they can order that will look at several genes for low calcium, and so I would suggest doing that, and it'll look at many genes. It's a blood test that they'll order and look at many genes at the same time. So that is usually the best first step, is that a physician would order that.
Okay, very good. And let's see, we have a question that says, my metabolic survey x-ray showed increased density in ulnas, radii, and femurs. Is this because calcium resorption isn't happening in my bones? And if so, is this a major concern? Is this something you would specifically be treating? Did they hear me?
I'll start and say, yes, this is, having higher bone mineral density is something that hypoparathyroid patients have. So that is a normal finding, and it is because that PTH is not absorbing the calcium out of your bones, so the bone density goes up. There are a lot of studies out there right now, and I'm not sure if somebody is speaking on that later today. I would have to look right now about
tomorrow. There's a talk about the skeletal effects.
Yes.
Yeah. So yes, lots out there.
Okay, very good.
Okay, I think we're going to go ahead and start Dr. Gaffney's portion of the presentation, and then we'll have more questions, folks. So keep the questions coming in the Q&A section, and we'll go over those after Dr. Gaffney speaks.
Okay, hopefully everybody can hear me and everybody can see my slides. If I don't hear from somebody that you can't, I'll just keep moving. All right, so I'm Rachel Gaffney. I've spoken at this meeting several times before. So thanks to everybody for coming, and particularly those on the West Coast who got up kind of early. So I appreciate your being with us. I'm just going to follow up from what Dr. Roszko was talking about and talk a little bit about treatments. So here are my disclosures. The NIH does receive research support from Calcilytics as part of a public-private partnership for clinical trials in autosomal dominant hypocalcemia. So I'm going to just talk really about treatments, and Dr. Roszko already spoke about conventional treatment of ADH, which is the same as for other forms of hypoparathyroidism. Patients have to take calcium in multiple divided doses per day, and vitamin D plus calcitriol. Some patients often also need extra magnesium, and this is particularly true in patients with ADH1 that tend to have low magnesium levels. This treatment is problematic because, as you heard, you still can only target the blood calcium to at or slightly below the normal range just to prevent symptoms, because if you raise the blood calcium too high, this increases the urine calcium and you can have calcium deposits in the kidneys. And you also saw this slide from Dr. Roszko showing that even before treatment, when the patients are very hypocalcemic, the patients in the right two columns with the activating variants of the calcium receptor with ADH1 have high or inappropriately normal urine calcium. And when they take calcium or calcitriol, the urine calcium goes even higher. So you're walking this treatment tightrope where you want to keep the blood calcium up high enough to not have symptoms, but at the same time, you want to keep the urine calcium down. So there are some additional strategies to try to reduce the urine calcium. One is to drink a lot of water. And we tell this to our patients all the time. You know, if you can dilute the calcium that's in the urine, it'll be less likely to deposit and form stones. Reducing salt intake is important because calcium and sodium kind of hold hands through the kidney together. So the more salt you eat, the more sodium gets put out in your urine and it pulls the calcium along with it. And then there's also using thiazide diuretics, which are a type of diuretic frequently used for blood pressure, but they also increase reabsorption of calcium from the urine into the bloodstream. They're not that well studied in hypoparathyroidism or ADH, and they can cause other electrolyte problems. So it's unclear how beneficial they are in hypoparathyroidism. So what about using parathyroid hormone therapy in ADH? And I know that there's a whole nother talk about PTH therapy, so I'm not going to go into this in detail, but I'll just briefly review. There's two types of PTH for injection. One is PTH 1 to 34, which is also called teriparatide. It's marketed as under the brand name in the United States as Forteo, and it's FDA approved for osteoporosis. And you can see the molecule on the left is the full intact PTH molecule, which is 84 amino acids. This teriparatide is only 34 amino acids, and that's where the biological activity of the parathyroid hormone resides. And that's why you can give this small PTH fragment and still get an effect. Another form of PTH 1 to 34 that's under investigation is called transcon PTH, and you'll hear more about research with that drug. Then there's the intact PTH or PTH 1 to 84, which was marketed as Natpara in this country and was FDA approved for hypoparathyroidism, but has been on hold for packaging issues. And I missed the talk yesterday, so I'm not sure what the update on the re-release is, and you guys can tell me at the end. So the issue is that PTH therapy is not well studied specifically in the disorder ADH. It's only been studied in small groups of people with ADH. Most of the studies are in patients with post-surgical hypoparathyroidism, which is obviously the most common cause of hypoparathyroidism. These small studies in ADH patients, they have been treated with both intermittent injections and continuous infusion pumps. And in fact, patients with ADH were specifically excluded from the large studies that led to the FDA approval of PTH 1 to 84 for hypoparathyroidism. And what we see in general with these intermittent injection regimens is that they can manage blood calcium, but they do not completely normalize the 24-hour urine pad, the 24-hour pattern, and can have unintended effects on kidney and bone. And so what do I mean by the normal 24-hour pattern? So this graph shows you how the PTH production by people without parathyroidism over the course of a day. And so the x-axis shows the time of day, and for some reason they chose to start at 2 p.m. and end at 2 p.m., which is not the way our brains normally think for a graph, but that's what they did. And you can see on the y-axis is the parathyroid hormone level, with the normal range here being 1.5 to 7. So these are healthy individuals without hypoparathyroidism who have normal PTH levels within the normal range. But what you see is here in the middle of the night at around 2 or 3 a.m., there's a rise in parathyroid hormone. This is a normal physiologic rise that occurs, and then it comes back down into the normal range or into the lower part of the normal range in the morning. Now, when you give somebody an injection of PTH 1 to 84, which is usually given first thing in the morning, you see that the PTH level here, shown in the black circles, goes up very, very high, way above the upper limit of normal, and then comes back down and is quite low again already by 12 hours. So this once a day injection is not at all mimicking normal physiology in people as you might see in somebody without hypoparathyroidism. In addition, we found in our study of twice daily PTH 1 to 34 injections, this was one patient who was treated for 5 years with PTH. He was a 40-year-old man with ADH1, and his renal ultrasound at baseline was normal. He did not have any nephrocalcinosis. But after 1 year of PTH 1 to 34, he did have nephrocalcinosis. So it certainly seemed that the PTH did not prevent the development of nephrocalcinosis. What about using PTH in the long term in people with ADH? There's really not a lot of data, but this particular study or case report is of a specific patient who received PTH for many, many years. She's at the time of this report, she was 20 years old and she had ADH1, and she had been treated for 14 years continuously with PTH 1 to 34 twice a day. Despite this PTH treatment, her urine calcium remained elevated. And while she didn't have any nephrocalcinosis when she was 6 years old, when she started PTH, she had extensive nephrocalcinosis by age 19. So the PTH did not prevent the nephrocalcinosis. Her bone turnover was higher than normal, and her spine and hip bone density were very increased. Her forearm bone density, on the other hand, was decreased, showing that intermittent PTH injections have different effects on different compartments of bone. So this is her head CT at 18 years of age. And what you can see here is that her skull is very thickened, and there are these areas of patchiness where you'll see white areas where the density is increased, and then these black little circles where the density seems to be decreased. And just for comparison, this is the head CT of an adult patient with ADH1 who was not treated with PTH. So clearly the bone turnover is not quite normal with this PTH therapy, because giving injections twice a day with PTH 1 to 34 is not replicating normal physiology. So one question is, maybe giving a long-acting PTH will better replicate the typical 24-hour PTH profile. So this is where this new drug, TransCon PTH, comes in. This is a longer-acting form of PTH 1 to 34. The way it works is this PTH, which is shown here by the little orange squiggle, this is PTH 1 to 34, is bound to this larger molecule called a carrier and a linker. And when you inject this PTH and it's exposed to the pH and the temperature of the body, it gradually releases PTH into the bloodstream in a more continuous fashion. And then the linker is excreted into the urine, and the PTH acts at the receptor and does all of those things to raise blood calcium. So recently, the phase 2 results were published from this study, and they included 49 adults with hypoparathyroidism, but none of them had ADH. However, the phase 2 data was very promising for these other types of hypoparathyroidism. You can see on the left that the blood calcium was maintained within the normal range for 6 months while on this TransCon PTH, and the 24-hour urine calcium on average decreased into the normal range. 100% of the patients were able to stop their calcitriol, and 94% were off of their calcium. So this was very reassuring data for patients with other forms of hypoparathyroidism. So they're currently conducting a phase 3 study. And the good news is that this current clinical trial does include patients with ADH. So this is good news for PTH options for ADH if this, the data from this study is good. But remember that even PTH therapy will not have any effect on how this calcium sensing receptor is acting in the kidney in patients with ADH1. So clearly better treatments for ADH are needed. This is a little timeline of the parathyroid gland and research that's gone into it. The parathyroid glands were first identified in the late 1800s, first in a rhinoceros in the UK, and then in some other animals, cats and dogs, and eventually humans. And then in 1925, that was the first time parathyroid extract was given to a dog without parathyroids and showed that it could correct the tetany. But then interestingly, it was almost 20 years later, 100 years later, when PTH was finally approved for hypoparathyroidism in adults, but it still didn't mimic perfectly physiology. And, you know, when I talk to people about PTH therapy and why we're not quite there yet, remember about patients who have diabetes who take insulin. Insulin was isolated and developed as a drug around the same time in 1922. And here we are almost 100 years later, and we still haven't really perfected all that needs to happen for perfect diabetes control with insulin. So we're advancing very quickly now with parathyroid hormone, but it's still going to take some time. In 1992, the calcium sensing receptor was identified. So again, about 20 years ago. And in 1994, almost 30 years ago, I'm losing track of time. And in 1994, variants in the calcium sensing receptor were found to cause ADH. So we're making some progress here. And in 2000, a class of drugs called calcilytics were identified. So that's just over 20 years ago. So what's a calcilytic? Calcilytics are from a class of drugs that turn down the calcium sensing receptor. They reset that thermostat that Dr. Roszko was talking about. And in doing so, they make the parathyroids and the kidney less sensitive to the blood calcium level. And as a result, the parathyroid glands will increase PTH secretion and the kidneys will hold on to calcium and not put it out into the urine. This class of drugs was originally developed as potential therapy for osteoporosis. And so it was given to over 1,200 women in clinical trials. But what happened was these women had an increase in blood calcium and an increase in PTH, but it didn't improve their bone density. It didn't help their osteoporosis. But the good news was that it had a very good safety profile. So our studies are a repurposing of existing drugs for this very rare disorder, H, that is specifically due to these variants in the calcium sensing receptor. So again, calcilytics turn down the calcium sensing receptor, promoting the production of PTH. So when the blood calcium is low and the calcium sensing receptor is activated, the body doesn't make parathyroid hormone. But when treated with a calcilytic, now the calcium sensing receptor recognizes that the blood calcium level is low and starts to make PTH. And then the blood calcium level comes back up. Likewise, in the kidneys, when the calcium sensing receptor is activated by these pathogenic variants, urine calcium levels are high. But when we treat with a calcilytic, this changes the sensing in the kidneys, and now urine calcium is decreased. So animal models of ADH1 have been treated with calcilytics and showed improvement in blood calcium and decreases in urine calcium, which was very promising. So this led us to the first calcilytic study in humans, which we did at the NIH in 2014. In this study, we treated 5 patients with ADH1 with daily IV infusions of a calcilytic called SHP635 in increasing doses. And these were brief infusions. They were not receiving any calcium or calcitriol at that time. And our major questions were, will it increase the PTH levels? Will it increase the blood calcium levels? And will it decrease the urine calcium? So what we saw, which was exciting, was that with the infusion, the parathyroid hormone levels increased. And that is really great news because it told us right away that the parathyroid glands were able to function. They had all the machinery they needed, even though they hadn't been producing much parathyroid hormone for decades in several of the patients. Unfortunately, this brief infusion did not result in an increase in blood calcium level. And we saw a trend in the decrease in urine calcium, but it was not statistically significant. So the next step was to take higher doses, longer duration, and possibly find an oral calcilytic that we could use. So that brings me to our current study, which has a very long name. It's a phase 2B study. It's open label, so there's no placebo. It's dose ranging, so we're looking at different doses, and we're trying to see if it's safe, if it's tolerable, and how the blood and urine levels change in patients with ADH1. So this is the design of the study. It has 4 periods. Period 1 is an individualized dose escalation period. There were 6 patients in that study. Period 2 is a 5-day inpatient visit as individualized dose titration. And we had 13 patients, so 7 new patients and 6 patients from the first period participate in period 2. And then period 3 and the long-term extension are outpatient periods that are ongoing. We presented the period 1 results in March at the Endocrine Society, and we just presented the period 2 results at the ASBMR meeting in October. So what did these patients go through for the study visits? Well, they came for a screening visit to the NIH to assess their eligibility. And then during the 1-week overnight stay, they got once or twice a day increasing doses of encaleret with very frequent blood and urine sampling, 10 to 18 times a day. These patients were real troopers. And then the first 6 patients plus an additional 7 patients came for period 2, which was again a 1-week overnight stay. And at this visit, they were treated with twice daily encaleret with blood and urine sampling. And then period 3 is the 24-week home treatment, where they came back to the NIH every 8 weeks for 24 hours of frequent sampling, and this is still going on. And then the long-term extension is 2 years of home treatment with visits to the NIH every 6 months. And the main goals of the study are to assess the safety of the drug and determine the best dose that will increase and stabilize the PTH, increase and stabilize the blood calcium, decrease the urinary calcium, decrease and stabilize the blood phosphorus, and increase and stabilize the blood magnesium. So what are the risks associated with this drug? Well, the risks in the osteoporosis study were related to having an increased calcium and PTH level. But of course, that's the desired effect in our study. Of course, there's a risk if the drug doesn't work, the patients could become hypocalcemic. So we monitor patients very closely, both inpatient and outpatient. And we were available to give them rescue calcium or calcitriol as needed, which I will tell you we did not need to do, at least not so far. If the dietary intake was less than 1,000 milligrams per day, daily supplements were given, but all but 1 patient was able to eat more than 1,000 milligrams per day. And none of the osteoporosis studies had any specific safety signals other than those related to hypercalcemia. So these are the baseline characteristics of our patients. So remember, we have 13 patients total, 6 in the first period and 13 total in the second period. 8 of the 13 were women, and the mean age was 39 with an age range of 22 to 60. 10 of the patients had nephrocalcinosis on kidney ultrasound at baseline. And the mean QTC interval on their EKG was prolonged, and that is very typical in patients who have hypocalcemia to see a slightly long QTC interval when you do an electrocardiogram. The calcium levels were in the low or slightly low, below the lower limit of normal at around 8, and the parathyroid hormone level was also low. The phosphate levels were high, and the magnesium levels were in the low normal range. And the 24-hour urine calcium excretion was elevated. The mean level was over 400. All of the patients were on pretty typical doses of elemental calcium and calcitriol. And the calcium, these 13 patients had 9 different calcium sensing receptor variants. So some of them were related, and that's why they're not all different, but we had some siblings and parents and children also participating in the study, and adult children. So all the patients were adults. So here's the dosing for our study. This is period 1 when we just had 6 patients, and the dosing was the same every day for the patients. On day 1, the patient took 30 milligrams once a day. On day 2, they took 90 milligrams in the morning. On day 3, they took 180 milligrams in the morning. And on days 4 and 5, they took 180 milligrams twice a day. So the first thing you want to look at is the drug absorbed? And you do that by measuring the actual drug level in the body. And these are the 5 days. And you can see that even with the 30 milligram, the level of drug in the blood went from 0 to measurable soon after the dose was taken. So this tells you with this little peak after every time the dose was taken that the drug was very absorbed as a pill. In addition, what you can see in days 4 and 5 with the twice a day, you can see that in between doses, the drug does not become undetectable. So it's staying in the bloodstream. So this certainly suggests that twice daily dosing is important. Now, when we looked at the parathyroid hormone levels over these 5 days, they mirrored the drug levels, which was really exciting because the parathyroid hormone level increased even with the first dose, up into the lower part of the normal range. In some patients, they even went above the normal range, but you can see here on days 4 and 5, we're getting very good parathyroid hormone level responses. So even though these parathyroid glands have been somewhat asleep for the entire life of the patient, as soon as they saw this medication and the calcium sensing receptor gave it the signal, parathyroid hormone was produced. The very exciting thing is we can see that over the course of these 5 days, the blood calcium went from very low, below the lower limit of normal, into the normal range at the highest doses. And likewise, the urine calcium excretion, which was elevated at baseline, also declined into the normal range on days 3, 4, and 5. These are the individual results for period 1. Here we look at the blood calcium levels. So these are our 6 subjects. And the light blue is the blood calcium level before they took their first dose. And you can see that all of the patients, except for subject 2, had blood calcium levels below the lower limit of normal, which is the shaded area. Now, the dark teal color here is their blood calcium level, their average blood calcium level on day 5. And you can see that all of them had blood calcium levels within the normal range on day 5 of period 1. Likewise, the urine calcium before taking encaleret, shown in light blue, was very high in 4 of the 6 patients. And in all the patients on day 5 had declined into the normal range. And in fact, on 3 patients was undetectable. Parathyroid hormone level also went from very low or undetectable to into the normal range, or even frankly elevated by day 5. Encaleret also reduced blood phosphate during period 1 from high to high normal levels into the normal range. And additional findings that I won't show you graphs for were the blood magnesium became normal, and that prolonged QT interval that we saw in the EKG that's associated with low blood calcium also became normal, and the drug was well tolerated. So let's look now at the data from period 2, which was 13 patients, and this was the period where the dose was titrated. It was very individualized over the course of 5 days, as opposed to everybody getting the same thing. And what we found was on the first day, everybody either received 90 milligrams or 180 milligrams twice a day. But by day 5, the dose requirements were very individualized, and these were adjusted based on the blood PTH and calcium levels and phosphorus levels. And what you can see is that by day 5, some patients only required 10 milligrams twice a day, while other patients required 180 milligrams twice a day. So you really need to individualize it for your patients. So in period 2, we saw that the twice daily encaleret also, just as in period 1, normalized the mean blood calcium levels shown here in the top panel, and also reduced the urine calcium levels into the normal range shown in the bottom panel. Twice a day encaleret also increased the average PTH levels shown in the top panel. And it's really, I mean, this is just an incredible profile. We're seeing these patients who have had low parathyroid hormone levels their entire life now are maintaining parathyroid hormone levels in the normal range over the course of 5 days. And likewise, the phosphate levels are also dropping into the normal range. Encaleret was very well tolerated. There were no serious adverse events reported. There were a few adverse events related to the drug, including hypocalcemia in one patient that was not severe. It was very mild and it corrected with an increase in the dose. Also hypercalcemia in one patient that was again mild and corrected with a decrease in the dose. And several patients had episodes of mild asymptomatic low blood phosphorus, hypophosphatemia, that again corrected adjustments in the dose. So this data that I presented to you is all in adults with ADH1, but it's important to remember that this is a genetic disorder, and we see a lot of, I'm a pediatric endocrinologist, so of course this often presents in childhood, as Dr. Roszko told us. So trials in children as well as pregnant women are also needed. So in conclusion, activating changes in the calcium sensing receptor cause a rare form of hypoparathyroidism called autosomal dominant hypocalcemia type 1. And conventional treatment of ADH1 does not address the underlying problem. PTH therapy has not been well studied in ADH1 and does not affect the altered sensing by the calcium sensing receptor. And calcilytics are drugs that turn down the calcium sensing receptor and may become an effective oral therapy for patients with ADH1. There are many people who have participated in this research, and there's a lot of people to thank, but most importantly are all of the patients who travel from around the country, especially during COVID, which was particularly challenging to participate in this clinical trial. So we can't thank them enough for their time and their effort to really move this research forward. And now happy to take more questions. We have plenty of time. Thank you.
Thank you so much. So Dr. Gafni, there is a question about, would you recommend that idiopathic patients be tested for ADH1 or just a general genetic testing for the idiopathic patients?
Yeah, you know, it's a great question because there's no perfect panel out there for genetic causes of hypoparathyroidism. So with genetic forms, you can somewhat subdivide them into what are called syndromic forms of hypoparathyroidism and non-syndromic. So ADH1 is a non-syndromic form because the patients don't have necessarily other associated features besides the calcium issues. Whereas other disorders like patients with variant GATA3 will often have hearing loss or kidney abnormalities, or people with autoimmune polyendocrinopathy might also have adrenal insufficiency or something like that. So the first thing to do is to really do a good evaluation and try to determine if it's an isolated form of hypoparathyroidism or if it's part of another syndrome. If it's really isolated, then it's probably reasonable to start with ADH1 testing with the calcium sensing receptor. But, and some of the panels, for example, some of the genetics companies will have a panel that's a screening test for forms of hyperparathyroidism, and they will include the calcium sensing receptor gene and the G protein that's downstream from it, because, and you might find mutations in that panel. Whereas some of the other panels, you might find them on a hearing loss panel, right? Because some forms of hypoparathyroidism are also associated with hearing loss. So it's there's a big table, and I think Dr. Levine is talking about genetic causes of hypoparathyroidism tomorrow. So he's going to go through that in detail, but there aren't panels right now that sort of hit all the genes for hypoparathyroidism at once that I'm aware of. So you really need to look for associated findings and the age and the presentation.
So a follow-up to that question then would be, if a patient has already had some genetic testing done, they would probably need to find out specifically what kind of panel they had, because there may be further panels that would benefit them.
Exactly, exactly. So if you've only had, for example, the Invitae panel that is really a hyperparathyroidism genetic testing panel, then you've only been checked for 2 genes associated with hypoparathyroidism and not the ARI gene or the PTH gene or the GATA3 gene or any of those other genes. Yeah. It's really important to look. It's really important to look at the panels. Yeah.
Okay, and then you brought up the Invitae testing. I know that you and that calcilytics that you talked about, the calcilytics drug, are doing some testing through Invitae for ADH1 specifically. Is that a different panel than what you just talked about?
So that's a panel that Invitae offers that it's geared towards genetic causes of hyperparathyroidism, but variants in the calcium sensing receptor and the G protein that's downstream from the calcium sensing receptor cause both hypoparathyroidism and hyperparathyroidism. So those 2 genes are included in that panel, but the other genes associated with hypoparathyroidism are not. So if you participate in that genetic testing program and don't have, and nothing comes up, that doesn't mean that you haven't been tested for all the other forms of genetic forms of hypoparathyroidism. You've only been tested for ones that cause ADH1 and ADH2.
Okay, and for those of you who aren't familiar with that testing, we will make sure that the information about the Invitae testing for calcilytics is on our website, so you can check there later. I have a question that asks, can you possibly have both DiGeorge syndrome and ADH1 at the same time?
Yeah, you can. I mean, I think it'd probably be pretty unlikely. DiGeorge syndrome or chromosome 22q11 deletion syndrome, it's really common. It's about 1 in 4,000 individuals. And not everybody has hypoparathyroidism, maybe about 50%. And again, Dr. Levine will probably go into this in more detail. So it's certainly possible to have more than one genetic condition. They're not related at all. ADH is very rare and DiGeorge is quite common. But, you know, there are some people that just get more than one thing. And, but I guess the question is why, what is making your doctor think that you have 2 things? Is it because the urine calcium is so high, or because there's somebody else in your family who has hypoparathyroidism who doesn't have DiGeorge syndrome? I mean, those are the things you might be thinking about that would make you wonder if you have 2 different genetic causes of hypoparathyroidism. But it, you know, it's always possible to have more than one thing.
Okay, we have someone that asked that mentioned that their 4-year-old has a pump with PTH 1 to 34, and he's had it since he was about 3 months old. His calcium levels are normalized. Since he takes potassium citrate, his nephrocalcinosis is stabilized. Is there any reason why this treatment was not mentioned?
Well,
I'm thinking she's talking about the pump therapy.
I did mention the pump treatment. It's just, it's not been studied. So it's not been studied. It's certainly not been studied in infants that young. All of the published papers are very small groups of patients that have been treated. The ones, you know, there was a study at NIH in children and in adults that looked at pump treatment compared to twice daily injections with PTH, but this was a very short studies too. These were like 3-month crossover studies. So there's really no long-term data that's been studied in a rigorous fashion using PTH in a continuous infusion pump. I mean, there's definitely cases. There was just a report in the New England Journal in this patient population showing that continuous subcutaneous PTH infusion reduced seizure frequency. So, I mean, I think that certainly continuous infusion is more physiologic than giving intermittent injections of PTH 1 to 34 or PTH 1 to 84, but there's actually no studies that have been done in children that are sort of in the pipeline for an FDA approval process or anything like that.
Okay, and then we have a question that says, can you share some results using the CASR antagonist in ADH1?
Yeah, I think that question was actually posted when Dr. Roszko was giving her talk. So
Oh.
that's what I just did. So
Oh, okay.
hopefully
I'm
that
sorry.
answered all of your questions. Yeah, I saw that
That one was a
question.
little over my head, so I'm not sure if it was
Yeah,
answered.
so that was like a stay tuned kind of question. Yeah.
And we have someone that asked, will the calcilytics drug ever be studied for post-surgical patients?
That's a really great question. And I hope it will. I can't tell you for sure because I don't work for the company and I don't know what their direction will be, but there is certainly a theoretical reason to think that it might be a useful component of treatment in hypoparathyroidism, right? So if you have post-surgical hypoparathyroidism, you don't have parathyroid glands. Or you might have some parathyroid tissue, but it's not working well enough. But in general, the drug wouldn't work that well to increase your parathyroid hormone level because you don't have parathyroids or functioning parathyroids. But it could still work at the kidney level to help reduce your urine calcium excretion. So theoretically, the drug, you could take the drug and then you could either take calcium and calcitriol or parathyroid hormone. And maybe, this is very theoretical, but maybe instead of keeping the blood calcium low, so low at 8, you could keep your blood calcium a little bit higher, like at 9, and maybe have fewer symptoms because you wouldn't be having as much calcium in the urine. But that's, that study needs to be done, but that is definitely a great idea. And I think there's a possibility it could work, but I don't know for sure.
Do you think that, related to that, would the calcilytic or encaleret be a safer option to lower the urine calcium than diuretics?
I don't know. You're talking again in post-surgical patients in general.
Yes.
Yeah, I mean, I think that's a really important question. I think we don't have good data that diuretics work well in lowering urine calcium. And we know that it can cause a low blood potassium, which can cause other problems. So I think it's a great question and I don't have the answer to it, but this is why we do the research, right? Because these great questions come up and we want to figure out the answers.
Okay, it looks like that's our last question that we have right now, but we want to thank you for all the great information today and for presenting to us. And for the audience, we have a break now until 12 o'clock. So we will see you all back at the next session at 12 o'clock. Thank you, Dr. Roszko. Thank you, Dr. Gafni.
Thank you.
Bye.
Did it end?
Not yet.
Is it touchscreen?
There we go.
Okay.